Hello everyone and welcome to ELPA Podcast, where we connect patients, clinicians and policymakers around better liver health. We are honored to welcome Professor Dr. Lisbeth van Rossum, Professor of Medicine, internist endocrinologist at Erasmus Medical Center Rotterdam, renowned obesity expert and a leading voice in the science of weight regulation. Professor van Rossum is also the co-author of the book Fat, the Secret Organ, the surprising science behind the most misunderstood part of the body. And in recognition of her groundbreaking work, she was appointed European Focus Area Leader in Obesity and Diabetes from 2020 to 2025. In Rotterdam, also Woman of the Year in 2021. I'm very curious to hear more about that, I must be honest. Professor van Rossum, what we especially appreciate is your belief that you stated that society deserves that we make scientific knowledge more widely accessible. We believe this is a strong statement and we are standing behind you. And that is exactly what we are doing today in this session, right?
Right.
So, Professor van Rossum, we are thrilled to have you. Welcome to Brussels.
Thank you so much.
So, today we are exploring how obesity and MASLD intertwine, what is driving both conditions and how new treatments and also lifestyle strategies can be. And we will discuss what obesity really is. It's a key question here. How fat tissue acts as an active organ, mechanism linking obesity and MASLD, current and emerging treatments, urgent call for integrated prevention and care, and also practical guidance on the topic of lifestyle intervention. So a lot of topics, so I think we should just dive into the conversation.
Sure.
So, Professor van Rossum, let's start really at the beginning. Many people still believe that obesity is, a little bit too of kilograms or a little bit too much of a weight, but medically speaking, this is a very complex situation, disease, diagnosis. Tell us a little bit more about that. Where can we start?
Sure. Yeah, you're right. For a long time, obesity was seen mainly as a matter of personal discipline, but now we know it's actually a disease of energy regulation. And the brain and the body, they are no longer in sync about how much fat we store. And in a healthy situation, the brain receives continuous hormonal signals from leptin, that's the fat hormone, from insulin, ghrelin, or hunger hormone, GLP-1, gut hormone, and other hormones. And that tell it when we have enough to eat, and also how much energy we have stored. But in obesity, this communication system becomes dysregulated. And the brain doesn't hear the signals properly, so it defends a higher body weight, and it makes it extremely difficult to lose weight and to keep it off. You're absolutely right that there are different types of diseases. A very small number of people, they have like monogenic obesity caused by a single genetic defect in these hormonal pathways. It's very rare. And these individuals, they develop severe obesity. And then it's the much more common polygenetic form where many small genetic variations, they make someone more vulnerable to gaining weight. And especially when they're exposed to our modern environment with constant food availability, stress, poor sleep, little movement. And add to that other biological influences like medications or hormonal disorders, and the body's regulation of this weight simply shifts upward. So this is at an individual level, but of course, as we all know, the main societal drivers are our obesogenic environment, including also an unhealthy food environment. And so whether the trigger is genetic, environmental, or a mix of both, the underlying disturbances which develop are the same. So once obesity is present, the body actively resists weight loss. And that's a problem. And that's why obesity, it's not a lack of willpower, but a chronic biological disease that deserves also proper medical attention.
A very strong statement right at the beginning of the session. But let's go a little bit more practical, a little bit more deeper. So you mentioned that obesity is not just a number on a scale. You were very clear that these are much more deeper, complex things happening on the hormonal level. So I guess the measurement of the obesity is also not just, someone stepping on the scale, but there are different measurements. And I checked that European Medicine Agency defines obesity as having a BMI of 30 or higher, or BMI of 27 or higher with at least one obesity-related condition. So the question is, can we unpack it a little bit? What actually is BMI? And what do we mean by obesity-related conditions? And also, I'm curious, how is obesity actually measured in a clinical practice to make a proper diagnosis?
Yeah, well, you're right. Obesity is about much more than body weight alone. So in practice, we also measure waist circumference, sometimes also the weight to height ratio that's in the newer international guidelines, and if possible, we use also body composition analysis. And that's important to see how much fat mass and how much is muscle of the total weight. So we also check for metabolic complications, blood sugar, insulin resistance, liver enzymes, also lipids, and someone's blood pressure. And for example, a person who has a BMI of 28 but very high visceral fat, it's the bad fat, and has metabolic abnormalities, they may actually be at a higher risk than someone who has, for example, BMI of 35, who's metabolically healthy. So, for example, bodybuilder. And BMI is a measure of your weight in relation to your height. So to answer your question, we combine anthropometric measures, so height and waist and weight, with metabolic markers, but also with hormonal markers. And that gives us a more complete picture, not just how heavy someone is, but how their body fat is behaving.
You mentioned also the body composition. So I think it's also important for our audience to understand that your weight is not just that number on a scale, but then it's a question, okay, what is the percentage of muscle mass or of fat tissue mass and also water in our body. So we could probably also devote the whole session about that, about these different components, but since you literally wrote a book, a very famous book also, because we had a conversation that your book is also translated in many languages, so there is no excuse for no one out there not to read that book. So the book is called Fat, the Secret Organ, the Surprising Science Behind the Most Misunderstood Part of the Body. And it's totally fair that we dive a little bit into this topic. And I would also like to remind that next year, in 2026, there will be a brand new, completely revised edition with the latest research translated for a broader public, and that is available until October 25. Tell us a little bit about that. Why the new edition? Does it go together with your statement that we have to make the science and scientific knowledge available to a wider public? Is that the connection?
Yeah, I think out there in science there's so much known, and people, the lay audience, but also a lot of healthcare professionals still don't know because it's brand new science. And I think in obesity there is so much new knowledge. And this, I think it's an important question because most people still think of fat as something very passive, just storage or insulation. But in reality, fat is an active living organ, and our fat tissue is made up of fat cells. We call them adipocytes, but also of blood vessels, immune cells, and nerve fibers. And together they form an organ that constantly communicates with the rest of the body. In fact, fat produces and releases dozens of hormones and signaling molecules. They're called adipokines. And they affect almost every system, our brain, our liver, muscles, pancreas, and even also the reproductive organs. And in healthy amounts, fat is actually essential. It helps regulate energy balance, supports hormone production, and it protects us also from starvation. But when fat tissue expands too much, especially the visceral fat around organs, it becomes dysfunctional. And instead of releasing helpful hormones, it starts sending the wrong signals. It produces inflammatory substances, increases insulin resistance, and it disrupts the brain's ability to sense fullness or hunger. So in that sense, fat starts to act as if it has its own mind, and it disrupts our appetite regulation system. And it facilitates also signaling for more storage, even when the body doesn't need it. So that's why in our book we call it an organ with a mind of its own, and it has its own metabolism, its own communication network. And when it's out of balance, it can drive diseases like type 2 diabetes, fatty liver like MASLD, cardiovascular disease, depression, and even some forms of cancer. Also, understanding fat as an endocrine organ, not just a number on a scale, that changes everything. It shifts the conversation from blame and willpower to biology and medical care. That's a big step forward for both patients and also for doctors.
I think this is a very important statement also, that it's time for the society to switch this mindset about what obesity is, that it's indeed a disease. We have scientific data. We can back that statement with clear numbers and clear research results.
Yeah, and it also shows how important prevention is. So once you have obesity, it's hard to treat, but it also shows how important prevention is. Yeah.
So to summarize, you're saying that fat isn't just a reserve, it's actually a smart organ, endocrine organ that should be studied and should be on our radar when it comes to obesity, but also liver diseases, MASLD. And I'm switching and we are diving into this intertwined area between MASLD and obesity. So what makes this visceral fat that you mentioned, that deep fat around our organs, so harmful for the liver? And how does it trigger inflammation, insulin resistance, and ultimately fat buildup in the liver?
Yeah, let's start with the visceral fat, sort of the bad fat, because that's often where the trouble begins. Unlike the fat that sits just under your skin, visceral fat surrounds our internal organs, so the liver, pancreas, intestines, and it's metabolically very active. When we store too much of it, the fat cells become overloaded and starts to releasing fatty acids and inflammatory molecules directly into the portal vein, which goes straight to the liver. So the liver gets bombarded with free fat and inflammatory signals. At first, the liver tries to cope by storing the extra fat, and that's what we call steatosis. But over time, this overflow triggers oxidative stress and inflammation inside the liver, and immune cells are activated, and the liver starts producing its own inflammatory signals. And that creates a vicious circle. So that's when simple fatty liver can progress toward MASH. That's the more advanced inflammatory and fibrotic stage of the disease. Now, add insulin resistance to the picture. When the body becomes resistant to insulin, often because of the same inflammation, the muscles take up less sugar, and the liver keeps making new fat, even when it shouldn't. So high insulin levels actually stimulate the liver to produce and store more fat. And that's why obesity and MASLD almost always travel together. And they're both symptoms of the same underlying metabolic dysfunction. And then, as you mentioned, there's also the communication between the brain, fat, and liver. Fat tissue, the liver, and the brain, they are constantly talking to each other through hormones and nerve signals. When the communication breaks down, for example, when the brain no longer senses the right leptin or insulin signals, it starts to defend a higher body weight and keeps promoting fat storage. And meanwhile, the liver continues to accumulate fat because the brain doesn't receive the signal that the body has enough energy stored. So all these systems, the fat tissue, liver, the brain, they are part of one big metabolic network. So when one goes out of balance, the others follow. And that's why we no longer treat these as isolated diseases. We treat them as parts of a single cardiometabolic continuum. And the good news is that by improving one part of the system, whether through weight loss, medication, or lifestyle change, we often see benefits across the board. So lower inflammation, better insulin sensitivity, and less fat in the liver. It's a very connected story.
Professor van Rossum, you mentioned the cardiometabolic continuum. This is now also a big topic, also in the scope of policy, European policy, since we are waiting for the famous cardiovascular plan. And I believe, and also ELPA believes, it's important that we stop working in silos, that we really start to addressing all of these diseases as the one big basket, and especially in the scope of prevention. My question to you is, where do you see, or what, from your perspective, what are 3 key areas of focus for prevention? Where should we, as patient advocates, clinicians, policymakers, we have information, where should we really put our energy to stop these conditions before they start? Because I have this sense of feeling that there are information out there. Sometimes there are not very relevant information, but that's a topic for another podcast. The health literacy, what do you think? Are we there with the health literacy? We need also more focus as a scope of prevention on health literacy. What are your thoughts on that? Where should we focus prevention strategies?
Yeah, you're absolutely right. Despite the enormous amount of information available, true understanding of obesity and MASLD, fatty liver, is still limited. And prevention really requires us to focus on a few core areas. First, we need to address upstream drivers, the environments that promote weight gain and metabolic dysfunction. That includes also improving access to affordable, healthy food and raising prices of unhealthy food, for example, sugar tax, and creating living environments that make physical activity the easy choice. Without changing the context people live in, individual prevention is extremely difficult. Now, second, we must strengthen early detection and risk stratification. So many people develop metabolic dysfunction years before obesity or MASLD is formally diagnosed. So simple tool in primary care, such as measuring waist circumference, checking liver enzymes, metabolic markers. And when overweight is present, check the causes. Lifestyle causes, stress, sleep, hormonal factors, sometimes weight-inducing medication. There's actually a new tool out there. It's www.checkcausesobesity.com. And people can fill out questions, and they're algorithm-based, and you can see what's going on, which cause or contributing factor you have. And the earlier we intervene, the more effective and less costly prevention becomes. The third we need to invest in health literacy and personalized support. People need clear information about how these conditions develop. And importantly, they need support that fits their lived reality. Stress, time pressure, financial constraints, stigma. So tailored guidance is far more effective than generic advice. So for patient advocates, clinicians, and policymakers, I would say create healthier environments, catch risk early, and support people with the right information and tools. And yeah, if we focus our energy there, we can truly prevent a large part of the cardiometabolic continuum long before disease takes hold and treatments are needed. I think we should go that way.
As we move, or if we move from the prevention to treatment, I would like to a little bit step back and look at the bigger picture. So we all know that numbers of obesity, MASLD, cardiovascular diseases, the numbers are rising, right? Also, despite ongoing research, new medications, and growing public awareness. So that makes me wonder, what maybe are we still doing wrong? Where are we lacking? You've been emphasizing how these diseases are deeply interconnected within the cardiometabolic continuum. So I would like to hear your thoughts on what integrated care really means in this context. So how can we strengthen the communication and collaboration between different medical specialities and also between healthcare providers and patients themselves? How we can bring all of these parts together?
Yeah, well, that's exactly where integrated care still falls short. Our system remains too fragmented, even though obesity, MASLD, diabetes, and cardiovascular disease all belong to the same cardiometabolic continuum. And we need smoother communication and better coordinated pathways across specialties. At our University Medical Center, Erasmus Medical Center in Rotterdam, we tackled this by setting up the lifestyle front office as a referral desk. And in the consultation room, the specialist of any specialty briefly checks whether a patient needs lifestyle or social support. And if so, if a patient is open to this type of support, they refer them to the lifestyle front office. And there, patients undergo a structured screening of lifestyle factors, of psychosocial challenges, but also medical contributors such as weight-inducing medication. And then the lifestyle front office then coordinates medication optimization with the patient's own medical specialists, while at the same time lifestyle and psychosocial support is organized outside the hospital. They are being referred to that, and ideally, of course, close to where the patient lives. And importantly, integrated care also means partnering with the patients, giving them clear information, involving them in decisions, and helping them understand how lifestyle, psychosocial factors, and medical treatment fit together. Even when part of the care happens outside of the hospital, it remains fully embedded in the integrated, coordinated approach. And this is a system which we're now implementing nationwide in the Netherlands in more and more hospitals, and this is really a way how we can make treatments more effective.
Indeed, treatments more effective, but also I believe that it's really like patient-centric approach, right? We really want to see patient at the center. We don't want to see patients running around, being lost in the system. They need safe environment, safe guidance, reliable system to go through the journey, which is already can be challenging, right?
Certainly.
So moving forward, the WHO officially recognized obesity as a chronic disease in its landmark 2000 report. And I think that's really important because it really puts obesity there as like a fully recognized disease more seriously, not only medically, but also politically and socially. So we need stronger preventive measures, better knowledge sharing, and access to real treatments, as you mentioned. So based on that, my next question is about the current treatment landscape. So what kinds of medications are now available for people living with obesity? And also, as an important follow-up, since obesity affects also the whole body, as you said, systemic inflammation and so on, can these medications also have an impact on other organs, other diseases? Tell us a little bit more about that.
Yeah, we now have several anti-obesity medications that work on the brain and on the brain-gut axis. And they act on hormones that regulate appetite and also energy use. And the best known are the GLP-1 receptor agonists. There are also other oral medications. And there are newer dual-acting drugs. They are also becoming available. And these medications help the body restore balance, making it easier to reduce food intake and to make healthier choices and to lose weight. It's not by willpower alone, but by resetting the biological signals. Interestingly, these medications don't just help with weight loss, they indeed also improve many obesity-related diseases. So they reduce visceral fat, they improve blood sugar, cholesterol, blood pressure, and even liver fat. And that's highly relevant for MASLD, so fatty liver. So it's not that they're cosmetic, they target the metabolic dysfunction behind several chronic diseases, also sleep apnea, infertility, heart disease, chronic kidney disease, liver disease. So, of course, as I always emphasize, these medications should be used alongside lifestyle changes. So, of course, diet and exercise, but also sleep and stress management, and importantly, always under medical supervision. So medication supports biology, but lifestyle remains the foundation.
We will jump into the lifestyle intervention quickly, but maybe we can stress the fact that you mentioned that, because for MASLD and MASH, the fact that the disease is reversible is important. So maybe this is also important statement there for liver patients, maybe also fighting obesity, that these treatments can also reverse MASLD, of course, if catched in an early stage, but I think this is also an important fact to mention here. But we are indeed jumping into the lifestyle intervention because more than 65% of scientific guidelines highlight the lifestyle intervention. So it's absolutely true what you stated just a minute before, that this is very important and should be combined with the treatment. So let's dive into it. So how important is lifestyle intervention really? Some might say that if the medication works, why would I focus on the lifestyle intervention and try to choose healthier choices on a daily basis?
Yeah. Well, yeah, it's easy to think that medication alone will do the job, especially now that we have powerful new treatments. But the reality is that medications and lifestyle work best together, not one instead of the other. The medication helps by calming the biological drive, so it restores the brain-gut signals that control appetite and hunger, which is defect in obesity. But it doesn't automatically teach us how to live in a healthy environment and how to choose food or how to manage stress and sleep. Those are all equally important biological signals that affect our metabolism every day. So think of it like this: the medication gives your body the chance to change. It makes it possible, but lifestyle change is what makes it last. So without that, when the medication stops or if other lifestyle factors come in, stress, poor sleep, little movement, the old biology can quickly take over again. So lifestyle intervention also has direct effects that medication can't replace. For example, physical activity improves muscle insulin sensitivity. Sleep regulates hunger hormones like leptin and ghrelin. So you're more hungry when you have a lack of sleep. Stress management, that lowers cortisol. And we know cortisol directly affects fat storage, affects your hunger, cravings, and affects liver health. So yes, the medication is a major step forward. It's a biological tool, but lifestyle is the foundation. And one without the other simply doesn't deliver lasting results.
So you are saying lifestyle, it's an essence, it's the base block, and you're also saying that medication can help the biology, but lifestyle is what keeps you going, and it should also be continued to. We all should strive to live healthier and
yeah, people often think you get rid of your obesity by only lifestyle. In severe obesity, that's often not enough, but it's the basis to make you mentally and physically healthier. And then on top of that, you sometimes need the obesity medication or bariatric surgery, but it's a basis for general health.
So Professor Van Rossum, my next question is about the stress management. This is also your area of expertise. And I really don't think that we unpack it enough. Since you often emphasized already the importance of sleep, there must be a connection also between the stress, sleep, and the hormones that regulate the hunger and appetite. So what is really this link between stress and our biology, and how does it affect both obesity and MASLD?
Well, yeah, absolutely. Stress plays a much bigger role than most people realize. When we experience stress, our body releases extra amounts of the hormone cortisol, which is meant to help us survive short-term danger. And that raises blood sugar, keeps us alert, and mobilizes energy, which is great if we are running away from a tiger. But today, most of our stress is chronic and psychological. Emails, deadlines, social pressure, maybe financial stress, and cortisol stays elevated for too long. And when that happens, it actually changes our metabolism. It increases appetite, particularly for sugary and fatty foods, so cravings. It slows down fat breakdown, and it directs more fat storage into the abdominal area. And that's called the visceral fat. And that visceral fat is not only harmful to our heart and liver, it also produces the inflammatory molecules that worsen insulin resistance and fatty liver disease. So there's a direct link biologically between chronic stress, obesity, and fatty liver, MASLD. And you're absolutely right, sleep is part of that same system. When we sleep poorly, cortisol rises, and other hormones like ghrelin, hunger hormone, they increase, while leptin, which is a satiety hormone, drops. So then that's why we crave snacks after a bad night's sleep. It's not just in our head, it's a hormonal response. So managing stress and improving sleep are medical priorities. It's not just lifestyle advice. You sometimes need relaxation techniques or time in nature or exercising or simply slowing down your daily pace. And it can all help to rebalance this hormonal axis. It's one of the simplest but most powerful ways to improve both mental and metabolic health.
So let's remind us, sleep is very important, and as you said, stress and sleep aren't just emotional emotional issues, but they are really biological drivers, and they can really affect our homeostasis of the balance of our whole body. So my next question is regarding the behavior change. So change of the behavior, because there are different things that we can address there. And there are also a lot of programs out there that you can look online and educate yourself on how to change your behavior. Maybe could you share an example from your own practice, something that could really motivate our listeners to take this first step, to jump on this train and try to change their behavior?
Yes, and I love that you're bringing this up, because this is where medicine meets the human side. So behavior change is not just about knowledge, it's about the whole person. The most effective programs are multidimensional, meaning they address medical, nutritional, psychological, and physical activity support. And there are also good practices, for example, from my own country, the Netherlands. We have many lifestyle programs. They are led by trained lifestyle coaches. They guide groups across these different dimensions and coordinate with physicians when needed. Because one coach supports multiple participants, like a group of 10 or 12. The model is very scalable. And over the past 5 years, these 2-year programs have been rolled out widely across the country in the Netherlands. And they're unique. They're fully reimbursed through the basic health insurance package. And their quality continues to improve, both in-person meetings, but also there are online lifestyle coaching formats. And they've already shown that they can significantly improve quality of life for people living with obesity. Lifestyle coaching is important because As you said, also, we are not just biology and physiology. We are also emotions, stress, behavior, and environment. And that's something I think patients' organizations like ELPA are also aiming for, promoting respectful, stigma-free communication. And the words we use really, they really matter. When patients feel judged, they close up. And when they feel understood, they open up and engage. So yes, behavior change takes time, often months or years, and it's never linear. But when we treat the whole person, not just the biology, but also the emotions and the environment, it's something the governments, of course, should do, that's when real and lasting transformation can happen.
Very true. We can sign under this statement too. I mean, it seems that the Netherlands is doing really good job. You know, you shared with us many good practices, and I really like, again, patient-centric approach, trying to give them safe environment and professionals from multidisciplinary teams. So good job there. But Professor Van Rossum, we are slowly ending this conversation of ours, and I think that you really helped us understand obesity. So this is not just a number on a scale, but it's a serious condition that should be taken seriously. Thank you very much also for explaining the interconnection with MASLD, with liver diseases, very important for our community. So at the end of this session, I would like to maybe give you a floor for any final statement, any messages that you would like to give to our audience.
So maybe as a final message, well, conditions like obesity and MASLD, so fatty liver, they're not about willpower or personal failure. They're shaped by our environment, a society issue that governments play a key role in, and they really should take preventive measures. But it's also shaped by our biology as individuals. We are genetically vulnerable, or how we behave. And understanding that is the first step towards effective treatment. And the good news is that we now have more tools, such as checkcausesobesity.com, and many treatments and support systems. And we have more tools than ever before. And by using them and implementing them, then we can move towards more effective treatments. And when we combine it with effective prevention, then we can gain a lot of health and benefit for patients.
Thank you very much, Lisbeth. First of all, for your time. We know you are super busy. Also for clear messages, clear information, and also for your compassion, because I can see that this is your topic and you really enjoy what you are doing. So in the name of ELPA and our community, thank you very much for all your hard work in the field. And I also think that many of our listeners will, after this session, feel a little bit more encouraged to look at their health and also in their body with a little bit more understanding and a little less judgment, if I may say so. So thank you very much to our audience, to everyone listening. And remember, small steps matter. Healthy lifestyle, awareness, and proper medical guidance are the most powerful tools we have. So thank you very much for being with us, and see you soon.